Hi, my name is Sharon Stevens, and I'd like to talk to you about conduct disorder in children. Conduct disorder is defined as exhibiting a repetitive pattern of antisocial behavior that disregards the basic rights of others, as exhibited by violations of societal rules or norms in four main categories: aggression to people or animals, destruction of property, deceitfulness or theft, serious violations of rules, generally before the age of 13. Now, all children and adolescents act out occasionally, but those with conduct disorder consistently behave in unusually aggressive ways. This diagnosis falls under the disruptive disorders in the DSM-5. Symptoms. The DSM-5 gives us 15 behaviors that fall into four categories of criteria. Children with conduct disorder can have normal intelligence, but have tendencies to disrupt, skip class, and fall behind in school. Now, in order to be diagnosed with conduct disorder, they would have to have 3 out of the 15 behaviors showing up within the past 12 months, and 1 would have been at least within the past 6 months. Some behaviors of bullying, threatening, stealing, fighting, forced sexual activity, break-ins, running away, forgery, truancy, are all type behaviors that would be seen in the typical conduct disorder child. Now, some specifiers according to the DSM-5 are the onset type. If the child has symptoms prior to the age of 10, this is considered childhood. If the child has no symptoms prior to the age of 10, then it's adolescent conduct disorder. Or if it's unknown the age of onset, DSM-5 has a category for unspecified age. Childhood onset is usually around 5 or 6. Typically, they are irritable, impulsive behavior, or defiant. The initial diagnosis can also come in the form of other diagnoses. Adolescent onset usually is less aggressive, with more normal peer relationships, more likely to act out with aggressiveness with peers. Limited prosocial emotions, 2 or more meet and persist over 12-month period. Typically lack of remorse or guilt for their actions, lack of empathy, unconcerned with performance, shallow, insincere, or superficial emotions can be seen in these type of children. Some characteristics can be the co-occurring diagnoses of ADHD or ODD, which is oppositional defiant disorder, and IED, known as intermittent explosive disorder. These are children that just go off like a rocket depending on what is going on with this situation. It's very hard to calm them down. There are problems with executive functioning. Children with conduct disorder often have these coexisting disorders. Some are mood disorders, anxiety, PTSD, and learning problems. Problems with executive functioning include the prefrontal cortex and the amygdala. Both have interworkings with the nervous system. Some studies conclude through the use of MRIs that increased amygdala activates an increased response to environmental cues. Also, hypoactivity with slow heart rate and reduced fear is reported in some children. The hypoactivity is also relational to the failure to learn from punishment, which is punishment resistance. Most frequently, this disorder is diagnosed in boys. Some statistics that can be found with conduct disorder is 2 out of 16 boys, 1 out of 9% of girls, and at least 50% have attention deficit hyperactivity disorder as a coexisting diagnosis. Conduct disorder being most frequently diagnosed in boys leads one to wonder if it's relational to the hormones of testosterone levels within boys or some boys. A 2008 study on emotional processing of boys with early onset of conduct disorder and comorbid conditions such as ADHD tended to exhibit high levels of aggression throughout development. The diagnosis of oppositional defiant disorder can be considered a precursor to conduct disorder. This is similar to conduct disorder in childhood, potentially developing into antisocial personality disorder. An adult personality disorder with lack of regard for right or wrong and for other people, originally termed as sociopaths. Developmental risk factors. Born with tendency to irritability, impulsiveness, or fearlessness in combination with environmental factors like rejection, neglect, physical or emotional abuse, brutal or erratic discipline, changes in caregivers, such as children in foster care, group homes, or just being shuffled from one home to the next, can increase these behaviors. Assessments. The assessments are all questionnaires that assess the child's behavior. The Child Behavior Checklist is a 4-page questionnaire checklist. Iberg's Child Behavior Inventory, ECBI, assesses different symptom domains, scale for problem and intensity. The New York Teacher Rating Scale for disruptive and antisocial behavior rates the child's responses from 0 to 5. Some intervention strategies for conduct disorder include psychosocial. These are programs to teach warmth and acceptance, parent management training, functional family therapy, cognitive behavioral therapy, problem solving and anger management. Group therapy is not recommended with these children. Medications are not recommended for conduct disorder. Medications are used to treat comorbid conditions like the ADHD and aggression and mood disorders. These attention focus are trying to teach empathy to children. The most empirical treatments for conduct disorder are the psychosocial combined therapy that focus on parent and family problem solving with the use of CBT. There is also a need for comprehensive focus on conduct disorder developmental pathways of the individual child. So that is how they develop the disorder at first. This would be the key to unlocking how we can help the child. Prognosis. The earlier the child begins therapy, the increased probability that treatment will be effective. Substance abuse decreases treatment outcomes. Family-focused therapy with CBT increases rate of effective outcome. In summary, conduct disorder is not just about a child acting out or being disruptive. We can't just label children that are acting out and disruptive with this disorder. This disorder requires the 3 out of the 15 behaviors that I spoke of earlier. It is consistent behavior in an unusually aggressive way that fall into the 4 categories of criteria comprising conduct disorder. Onset is typically 5 to 6 in childhood. And this is where you will see your most severe behavior patterns when it falls in these younger children. They are more likely to be more aggressive with more potential for antisocial personality disorder. The adolescent onset type of conduct disorder is typically less aggressive, and you see more patterns with their friends and their choices of friends. Coexisting disorders are oftentimes seen with conduct disorder, the attention deficit hyperactivity disorder, and the lack of focus, and also the ODD, oppositional defiant disorder, is one that can be diagnosed early on, which can change to the conduct disorder. And the intermittent explosive disorder is one that can be seen also coexisting with conduct disorder. There are multiple assessments that can be used to track the severity of this disorder and also how well they are doing with treatments. The earlier the child begins therapy, the greater the probability of an effective treatment is one of the most important takeaways from this presentation of conduct disorder. The scripture is Ephesians 6, 1 through 4. Children, obey your parents in the Lord, for this is right. Honor your father and mother, that it may go well with you, that you may live long in the land. Fathers, do not provoke your children to anger, but bring them up in the discipline and instruction of the Lord. I found this to be an appropriate scripture because it speaks not only to the child, but also to the parent. There is a lot of room for prayer, grace, mercy, understanding, love, and patience. A lot of patience with these children as the family does the work along with them to get to a good functional place in society. Here are my references, and I want to just thank you for watching this presentation, and I hope you enjoyed it.